Hello everyone, my name is Henny. I'm a medical doctor. I recently passed my AMC Clinical Exam and I will be doing some videos to share the tips and tricks that helped me pass this exam. Today's video is going to be about psychiatry and how to approach psychiatry cases in the AMC. By the end of this video, you know how to take a psychosocial history for the AMC exam. So let us start. First, let's have a look at the marking sheet that has been released by the Australian Medical Council. This is a sample marking sheet for a sample case of shortness of breath, which turns out to be a pulmonary embolism. So we can see that there are a few key steps for each case that we are marked on. If we do not get one or more of these key steps in our performance, it ends up failing the exam. So key steps are mainly the tasks, but they're not always limited to the tasks. So they're kind of a secret thing and no one actually knows what the key steps for each case are. Then we have a few domains that we are assessed in. We will be marked from 0 to 7. 0 means that we have not reached the task, and 7 means that we have thoroughly done it. A mark of 0, 1, 2, 3 means that we were insufficient within that, our performance has been insufficient within that domain, and 4, 5, 6, 7 means that we have done a satisfactory performance within that domain. So the domains are different for each case, and usually there are 2 or more domains that we are assessed in. Approach to the patient and relative will always be there in each and every case, and it's a very important domain. So a lot of people confuse approach to the patient with empathy. Well, empathy is part of approach to the patient, but approach to the patient is not solely limited. It's not limited solely to empathy. I'm going to give you some examples. For instance, a patient presents to us with pain. Just telling the patient, I'm sorry that you're having pain, is not enough. We have to address the patient's problem. We have to give the patient pain relief medication. Another example, a patient who presents to us and at a GP setting, and we have to send the patient over to a hospital. Just saying that I'm going to send you to the hospital does not mean that we're going to get a good approach. We have to say, do you have anyone to pick you up? Do you want me to call anyone for you? That's when we get the satisfactory mark or grade in our approach domain. Then we have the history. So the history is really different from case to case, so we can explain in further videos when we do more cases. Then we have choice and technique of exam and organization and sequence, which is mainly for physical exam cases and in cases that contain a PEFE task. PEFE stands for physical exam findings from the examiner, and is mainly in face-to-face exam, but sometimes we might have this task in the online exam as well. Another important domain that we are assessed in is our diagnosis and differential diagnosis. So there are a few points with regard to this. First of all, we have to mention our main diagnosis first, always, and then our differentials. As a rule, remember that for the AMC exam, we have to mention our main diagnosis plus at least 3 or 4 differential diagnoses for each case. Always mention the main diagnosis first. Always mention that this is the most likely diagnosis. And then proceed with the differentials. Other possibilities might be differential 1, differential 2, differential 3, differential 4. And then justify So my main diagnosis is most likely this because you had these findings in your examination and these findings in your history. My differentials are this, but considering these findings that you have, or these findings that you didn't have, or we can just say your findings weren't consistent with these, I would consider these to be less likely. So for those who are at the beginner phase, a global score of 4 or more means that we've passed, and 1 to 3 means that we have failed. No one knows how we get a global score. It's not the average of these domains. It's mainly based on what the examiner thinks of our general performance, what the role player or the patient thinks of our general performance, and it determines whether we pass or fail the case. Okay, so all right, so getting back to the psychosocial history, remember that in the AMC exam, we can only tackle and overcome this exam when we have structure. Without structure, passing this exam is going to be really difficult, and I could even say that it might be impossible to pass without structure. So this is these are the main parts of a good and thorough psychosocial history, but it doesn't mean that we have to do it in this order. So it changes from case to case. Sometimes in the AMC exam, the task is going to directly ask us to take a psychosocial history. That's when it's easy. But sometimes they might not tell us, and the task is just going to say, take a relevant history. And we will discuss further. That's mainly in cases where the patient presents with a somatoform or more generic presenting complaint, which we will discuss further. Okay, so first part is confidentiality statement, whether it's a critical error or not. Actually, about being a critical error, it doesn't really matter. What matters is that in the exam, the role players are instructed in a way that if we do not mention the confidentiality statement, they're not going to open up. We're not going to be able to extract the findings from them, and it's going to lead to failure. So it is very important to mention the confidentiality statement. About when to address it, there are two opinions. One group of people believe that as soon as we greet the patient, we have to mention the confidentiality statement because this is a psych case. There are other group of people which believe that it's very robotic to perform that way, and we have to greet the patient, start asking questions, build some rapport, and then ask a few generic questions. And then when we reach the personal and sensitive questions, that's when we have to mention the confidentiality statement, which is not wrong, and that's actually the ideal way. But in this exam, leaving the confidentiality statement for later, we're taking a big risk. If we don't mention it, the case is going to get out of control. So my personal suggestion is to greet the patient, signpost, mention why we're asking these questions, and then mention confidentiality statement. So I'm going to give you an example. So we greet the patient. We have to say, okay, John, Mary, whatever your name is, whatever the patient's name is, John, I am about to ask you a few personal, sensitive questions in order to assess your mental health status. And then mention the confidentiality statement. So what's the best way to say the confidentiality statement? So a good confidentiality statement should contain different parts. Number one, We have to mention that, of course, obviously, anything we discuss today will remain confidential, will stay between you and me, or whatever is the best way or preferred way for us to say it. Then we have to say, I'm not going to disclose this information unless there's harm to you or anyone else. And then the last part is to say, even if I have to disclose this information, it'll be only with another professional. And I will not disclose every detail of the information you share with me, and it'll be only the necessary one. But the last part is usually skipped, and it is okay to skip the last portion of the confidentiality statement because of time issues. We only have 8 minutes to perform our case, and confidentiality statement is a tiny part of it. Important, but tiny part of our performance. So we have to leave time for the rest of our performance. So the best way to say it is just to say whatever you share with me will remain confidential, and unless there's harm to you or anyone else. So that's the quickest way to wrap the confidentiality statement up. Next, so in every case in medicine, whenever we're taking history, whether it's a medicine case, surgery case, obstetric gynecology case, pediatrics, whatever, we have to start with history of presenting illness. So there are some mnemonics for medicine surgery cases, pain questions, Socrates, Sikora. We will discuss these further, but for psychiatry cases, there are 4 important parts that we cannot skip and we have to ask. It's the onset. So when this all started, how long have you been feeling like this? Trigger, has anything happened that, do you think anything might have happened that might have triggered this? Measures applied. How have you been coping? Do you think have you tried anything? Have you applied any changes to your lifestyle? What have you done? How have you been coping? And then the consequences. How has this affected your life? Your relationship with your friends, your family, your sex life, whatever is relevant. So there is one point about the measures applied. Some candidates mention, okay, so have you been drinking? Have you tried anything that you thought might have helped? Have you been smoking, drinking, or taking drugs? And they think it's a smart way to combine the drug history with the history of presenting illness. This is wrong, wrong, wrong. Do not say it, because it's going to mean that you're trying to imply that the patient should try smoking and alcohol or whatever. So do not mix your drug history, alcohol and drug history, with the measures applied. Just generally ask, have you tried anything? Have you applied any changes to your lifestyle? See if it works. All right. So another part of psychosocial history is the head. People have different mnemonics. Some people think that believe that the S in head is sex life. Some people say it's social life. Some people say it's smoking. And this is the structure that worked for me. So you can just try it if you like. So there's no right or wrong here as long as we cover the main parts. So we have to ask about the home situation, education, and career. Of course, it's based on us. And a 60-year-old man, or a male or female, presenting with low mood, asking about education is irrelevant. We have to ask about their career, whether they're retired, whether they're still working. So it's up to us. So home situation, who do you live with? And education and career. Drugs, we have a mnemonic called the SAD-MAC, which is smoking, alcohol, drugs, medication, allergies, and coffee and caffeine if relevant. And then we have social life. We can just basically ask, do you still socialize and do you have friends? Okay, the main part is mood. So about mood, there are different ways to ask it. Some people say on a scale of 1 to 10, 10 being your happiest and 1 being you at your lowest, how would you rank your mood? And this is suggested by some tutors, but in practically, this is a very weird question to ask if you think about it. So just my personal suggestion, just simply ask, how's your mood been? Have you been feeling happy, sad, or just okay? So the patient or the role player is going to give you 3 answers, might give you 3 different answers. First option, they might tell you, I'm very sad, I feel terrible, I'm having a low mood. That's when we have to continue asking the MCD caps. So this mnemonic is very important mnemonic for psychiatry. It's mood, sleep, interest, guilt, energy, concentration, appetite, psychomotor status, and suicidal ideation. So it's really important to proceed with this mnemonic and ask these questions. So a person with low mood, we just do not say, okay, I'm sorry that you have been feeling terrible, and proceeding with the rest of our history. We have to see whether they fit in the criteria of depression. So that's the whole point of asking the MCD counts. So we've already asked the mood. I put mood here again because we have to remember ruling out bipolar. When the patient says low mood, we have to say, have you been feeling the other way around? To rule out bipolar. Then of course sleep. For sleep we just ask, have you been having difficulty falling asleep? Do you wake up early in the mornings? Do you have any nightmares, flashbacks, or vivid dreams? So it's not generically asking, how's your sleep been? We have to ask all of these questions. Then we have interest. Of course, we need to ask, are you still enjoying things that you had interest in? Guilt, do you blame yourself for anything? Energy, have you been feeling tired lately? Concentration, are you able to concentrate on your daily activities? Appetite, has there been any changes to your appetite? Psychomotor status, we ask this way, we ask, have you noticed your movements to be a lot faster or a lot slower compared to your usual self? Suicidal ideation. This is a very sensitive question. We can emphasize again and just tell our patient that this is a routine screening question we ask every patient. So we have to ask, have you been thinking about dying? Have you ever thought of harming yourself or others? And of course, if the answer is yes, we don't just leave it. We have to ask the rest of suicide questions, which are, do you have any plans? Have you had any previous attempts? Do you have access to any sharp objects or any tablets? So we don't just leave it, we have to ask. Okay, so when the patient tells us that I've been feeling all right, my mood's fine, then there are a few screening questions we ask. There's guilt, suicide, and sleep is a plus or minus, but I personally believe that sleep is an indicator for our overall health, so never skip it. Then we have the elevated mood. So we have to immediately think about the mnemonic dig fast, which is distractibility, indiscretion, grandiosity, flight of ideas, sleep is less, and being talkative. So of course, most of the dig fast is what we observe in the patient, but the indiscretion, we can ask, okay, so you've been feeling very energized, and you say that you've been feeling great lately. So what have you been doing? Have you been partying? Have you been having sex? Have you been drinking or doing drugs? Have you been spending money on gambling or doing any investments? Grandiosity, I will explain in the delusion part how to ask it, and of course we have to ask sleep. How much sleep have you been getting lately? All right, then we have anxiety. So always remember to ask the patient, are you an anxious person? Do others consider you anxious? Do you tend to worry about different things? So we have to ask, and if the answer is yes, there will be another set of differentials and questions which we will discuss in our further videos on anxiety cluster. Then we have to ask questions regarding evidence to see whether our patient is having any evidence of psychosis. So we have hallucination. The three main ones that are important here are tactile, auditory, and visual. So we have to say, have you been seeing, hearing, or feeling things that others don't? It's really important to say the word seeing, hearing, or feeling. We shouldn't skip. So ask these three. Then we have delusion. So we have to ask, there are lots of delusions, we are all aware of them, but the three main ones that we have to explore is the paranoid, persecutory, and grandiosity. So for paranoid, we have to ask, do you think anyone's trying to harm you? Do you think anyone's following you, or anyone's spying on you? For persecutory, we can ask, do you think anyone's trying to harm you? And for grandiosity, we have to ask, do you think you're better than others? Do you think you have powers that others don't? Then about insight, cognition, judgment, it's really based on the case whether we need to ask it or not. So we can skip it sometimes in some cases, which comes with practice. We can get a grip of it. So about insight, a lot of people just say, do you think you need help? I personally don't like this question that much. I prefer to ask, do you think there might be some other causes to your problem, especially in somatoform cases where the patient is presenting, for instance, with something like abdominal pain and they think it's cancer? We can just say, do you think there might be another cause to your pain? And for other cases, we can ask, do you think someone like me would be able to help you? Do you think I would be of any help as a doctor? That's also a nice way to ask insight. Cognition we will discuss in the delirium cluster, and but to be fast about it, in other cases we can just ask, do you know where you are and what time of the day it is? And then we have judgment, which is the famous fire question. We have to ask, if there's a fire in this room, what would you do? Then we have the organic screen. Of course, organic diagnosis, organic problems could overlap, the symptoms could overlap with psychiatry cases. So we should always ask organic problems. So there are different mnemonics for it. There's CTP, there's T time, there's P time. This is the one that worked for me. So we have to ask, do you have pain anywhere? Have you been getting headaches? Has there been any trauma to your head? Have you been having any fevers, chills? And for malignancy, there's the famous questions that we ask in the AMC. There is loss of weight, loss of appetite, lumps and bumps, and night sweats. Then we have the endocrine or thyroid. And of course, if it's the female in the perimenopausal age, we have to ask perimenopausal symptoms as well. So for the thyroid, we can ask any lumps felt in your neck, usually people just say any weather preferences. So again, this is a very strange question to ask because all of us might or might not have weather preferences. So the best way to ask thyroid is to ask, has there been any changes to your weather tolerance? And of course, there is past medical and family history. It's important to ask any past medical or surgical conditions, any previous mental health issues. Never skip this mental health issues. The patient might be schizophrenic and not tell you because you didn't ask. And then for family history, we can just ask any family history of similar issues. Okay, so this is an algorithm that I made for psychosocial history format. Of course, confidentiality is in red. It's very important. These are all in the same category. We can, there's no order for it. We can change and alternate what we ask first. And then there's approach to mood based on the answer they give us. And we proceed accordingly with these different mnemonics that we have. Okay, so there are a few topics for mood disorder cluster. These are the most important ones. We have anniversary grief, empty nest syndrome, adjustment disorder, depression. We have major and minor depression with or without psychotic features. Make sure to read Handbook Condition 131. We have lifestyle stress, again, Handbook Condition 86, postpartum blue and psychosis, Handbook Condition 109, and we have bipolar disease. This is a sample case. This is completely made up, and yeah, it's a sample case. So you are a GP. Your next patient is a 22-year-old university student complaining of feeling lost for the past 2 weeks. She has been referred by the university counselor for possible depression and need for medication. Tasks are history for 7 minutes, explain diagnosis and differentials to the patient with reason. For those who are beginners, I want you all to know that we have 2 minutes to read the scenario and think about the scenario, and then we have 8 minutes to perform our case. So when you read the case, make sure to know what setting you're at. So we're in a GP setting here. Make sure to make note of the age of the patient, the presenting complaint, which is you're feeling lost, and always make note of duration so you wouldn't repeat questions and try to extract findings that waste your time on extracting findings that are already there on the step. So let's go back to the algorithm and see how we should approach it so we'll get an idea. So I would personally start with I'll greet the patient, mention the confidentiality, ask history of presenting illness. So the onset is already mentioned in the STEM. It says 2 weeks. Then we have to ask the trigger, anything that happened that might have led to this. Then we have measures applied. Have you tried anything? Have you done anything to make yourself feel better? And then we have consequences. How has this affected your performance at uni as our patient is a 22-year-old girl university student? So ask this. And then we can ask, can you tell me more about this? About what do you mean by feeling lost? So we should mention this right after confidentiality. Always, always, always start with an open-ended question. The role players in the exam are instructed in a way that if we do not mention open-ended question, they're not going to give us as much information. So, open-ended question. I can see from your notes, your case file, that you've been feeling lost for quite some time. Can you tell me more about it? Remember, whatever you share with me will remain confidential, unless it's harm to you or others. Okay, so what could be the positive findings for this case? So, in the history of presenting illness, when we ask the trigger, she's going to open up. She's going to tell you, my mom was diagnosed with cancer 2 years ago. This is when we have to immediately ask, was this around the same time now, to rule out anniversary grief? Because this case is the case of anniversary grief. We also need to ask, when your mom passed away, were you there? Did you witness anything that might have been traumatic or painful to you? Because this could be a post-traumatic stress disorder case. Positive finding in the heads. When we ask about home situation, family situation, she's going to tell us father remarried. She's not in good relation with the father and the stepmother. When we ask mood, she's going to tell us that she's all right. But sleep, she's got disturbed sleep and she's having vivid dreams of her mom. And there are no other positive findings for this case. So, how we mention diagnosis and differentials in this exam? I already gave you a brief idea how to mention diagnosis and differentials, but once you mention that most likely you're having anniversary grief, but based on your history and history findings, I'm led to believe that most likely you're having something we call anniversary grief. I will explain to you further, but I want you to know that I was also thinking about other causes for your condition, such as pathological grief, PTSD, OCD, substance abuse, and some organic causes such as problems with your gland or cancer. But don't worry, these are less likely, as your findings are not consistent with these. Then you have to go back to the anniversary grief and explain something which is famous in the AMC Clinical Exam, which we call the 6 C's. We have condition, clinical features, causes or risk factors, complications, commonality, and then of course we have care. Care is only when we have the task of management or investigations. Guys, sometimes some people might finish their case early and have like a minute or two left at the end, and they decide to explain management, even though management is not part of their task. So again, this is very risky, because if you mention anything wrong or unnecessary, you're risking your case. So never ever mention something that is not part of your tasks. Instead, invest the remainder of your time to build rapport, to address patients' concerns, to check whether the patient needs any further help. So, condition. Anniversary grief is a feeling of intense sadness that usually occurs during the anniversary of our loved one's death. It is a normal, expected human psychological behavior, so it's really important to reassure. Causes. You had a close relationship with having a close relationship with the deceived, painful and traumatic or sudden death. That could be risk factors. And we can also justify here in the causes, we can also justify why we think it's anniversary grief. So we have to say that your mom passed away 2 years ago around this time, and you've been doing well ever since. You've been doing well. But recently, her anniversary reminded you of her. In the past 2 weeks, you've been feeling lost. You've been getting frequent dreams. Your sleep's been disturbed. So I believe this is most likely a case of anniversary grief. If left untreated, it might have some complications. It might develop into a major depression, psychosis, and lifestyle disturbances. Don't worry, this is not an uncommon condition and it could be managed. So this is basically it. And last but not least, we have to know the criteria for pathological grief. Within the limits of this exam, we should know all the criteria, all the itty-bitty details of the criteria. Just knowing that continuously not coping with losing a loved one for over 12 months is pathological grief. That's when it's not normal. So in anniversary grief, after they're gonna go through bereavement, grief and bereavement for some time after their loved one passes away, but then they're gonna get back to normal slowly, and then something like a birthday, like an wedding anniversary, like some time some date on the calendar, for instance, might remind them of their loved one, and they're going to start feeling sad. They might or might not have a low mood. They might even have visual hallucinations of the deceased, and they might have vivid dreams and disturbed sleep and other symptoms, signs and symptoms. So that's when we say it's anniversary grief. Okay, so that's it for today's video. If you like my videos, subscribe to my channel. I'll be doing more videos on different cases related to AMC Clinical Exam. If my email is in my bio. If you want me to do any specific case for you, if you want me to crack any specific cluster for you, please let me know. Comment and leave a comment in the comment section and I'll make a video for you. Simple as that. So hope you have a great day and hope you enjoyed my video.